all the speakers have taken up most of my slides, so I guess I have nothing much to talk about. But anyhow, why are toric IOLs so popular? Well, they do correct the astigmatism. They are more popular than the other premium IOLs like the multifocals and the accommodative simply because the patients are happier. And if you have a happy patient, he's going to bring in more patients and you will not be attending this IC, you will be planting torics back in your clinic. Now, you can see what are slides I've left off with because they've fused all the slides I wanted to present. I will touch on prerequisites a bit before I go on to the main pitfalls. Problem solving is already being done. Now, what are the prerequisites? This also has been sort of dealt with. You've taken the regular astigmatisms, more than a diopter. You use the manual keratometer. There are a few contraindications touched upon, but I'd like to talk about things like keratoconus per se, Orbe fruste, conditions like Salzmann's, Terriens. These have a floating astigmatism. It keeps changing. So these are not ideal candidates which you put on the table. And there are certain other conditions which we can address prior to doing the procedure. And things like dry eye, you need to address dry eye. Suppose the patient is wearing a little contact lens. If there's a pterygium, excise it, wait for the astigmatism to settle. And if there's a mapped up dystrophy, you sort of scrape off the epithelium and wait and then take it all over. Now, everybody talks IOL master, but there's a little bit of A scan involved here too. And why? Because if you have a patient who's got a posterior polar, dense cataract, hypermat, you will have to go back to basics. You'll have to start with your A scan. And yes, you need to better go quickly through this. There will be refractive surprises if you don't do your A scan properly. It's not part of my thing, but I'd like to mention it here because if you get your axial length wrong, everything could fall apart. And as you can see here, there's wrong reading taken, and it's because the probe has been pressed on the eye, you got a short axial length, giving you wrong values. Yes, an IOL master would be preferred. No direct corneal contact, no indentation. But then, as I told you before, there could be some cataracts where you can't use an IOL master. And IOL power selection. Determine the required spherical lens power. And already the Bible is to use the manual keratometer. And definitely subjective refraction is not advised because of various changes. The experienced surgeon would use a 3-plane incision, already shown, no sutures, and the surgically induced astigmatism should be below 0.5. If you're really good, 0.2 is great. And studies have shown that the temporal over the superior approach is better, and sub 2.5 millimeter incisions are astigmatism free. This is a good video to show how you make the incisions. Capsular excess, already mentioned. Try to make the one on the right side and not on the left. Try to do quick surgeries. Doesn't mean that you should, if you have a delayed time, you would have corneal edema, chance of a wound burn, a suture. Everything ruins the prospects of a good toric IOL. Now let's get to my topic of pitfalls. The major errors are usually the preoperative measurements, incorrect markings, incorrect placements, and not accounting the surgically induced astigmatism. But I think, like most of the surgeons here, good phaco surgeons, small amount of SIAs. Now, calibration of devices is something which you really need to do. You don't have to do it yourself, but you get the companies which machines you own to come and do them routinely, at least quarterly. You need to calibrate your keratometer, your auto K if you have one, your A scan, your IOL master, and your topographer if you have one. Calibration is important. What are the do's prior to doing a keratometry for your patient? you do apply lubricants. You're going to get an age group which is going to basically have a bit of dry eye. So you will avoid topical medications, anesthetics. Try to avoid all the applanations you're going to do on that patient the day you're doing the case. Because case mean a lot, especially if you're putting in toric IOLs. I just mentioned that. Try to also look out for seborrhea. It could give you wrong readings. And this is a video here. It's not mild, but it's a placido. This, if you see the blinks, each blink would cause the things to become much clearer. So when you're taking your K, you should ensure that those rings come in well. So similarly, your Maya should come in clearly. So keep your manual K as the gold standard. But if you have other equipments which allow you to check for the K readings, do so. If you have a topographer, do so. Do not use the IOL master because there are a lot of interpolations involved when you're taking a K, especially for a toric IOL case. Whatever instrument you have. If you have a washing machine which takes K, use it. The reason you need to know is you can have a different set of Ks taken in your clinic and you will find that most of them should match if properly done. And if they do, then you're on because the chance of error is significantly reduced. The other thing to note when you're taking Ks, of course, patient should be upright, head correctly positioned, and look for things like a bit of dry eye clues or contact lens wearers. And another important thing is taking the correct readings. Take your own readings or get your most senior optometrist to take your readings or have a senior colleague whose results have been quite good all the while to take. Don't take the guy whose last job was a pizza delivery guy to take your readings and enter them into your machine. This is what will happen. You enter the K wrong and the patient is going to eat your head. It's not going to eat anyone else's head. Now the K values using a topographer. Same K values, some studies I was just going through, are in agreement with the diopters of the keratometer. They are both pre-op and post-op. So your regular keratometer works fine. Not going into topography. Corneal marking. Again, everybody said it, everybody does it, and it's very accurate. You can swivel to the axis that you want and do the marking. It's not. Again, the thing you need to look for when you're doing your marking is you make sure that the patient's head is well positioned. It's not tilted to a side. That you might be doing the perfect marking, but when you see the patient, very often you're seeing in your clinic the patient's head is not straight when kept on the straight line. This is a small video showing the marking. It's not difficult. There's no rocket science involved here. Speculum, topical anesthetic, and you put in a line. You can choose the axis because your slit cam gives you a whole camera 360 degrees. You can go anywhere you want, and you can clip it down to 2.5 degrees. So it's pretty accurate. Now going into a little bit of intraoperative error placements, like Dr. Arul did show this slide, but if you leave this like this, if you see the lines, the bold lines and the dotted lines are not in sync, this could be due to parallax. So you will have to get the Purkinje images coinciding to make sure it's right. Little bit of 2 to 5 degrees this side, that side can make a lot of difference. It did happen to one of the cases. The rotational stability, again previously mentioned, I'm not getting into that. And also Dr. Arul's mentioned about removing the lens from, the viscoelastic from under the IOL, which I think shows here well. Use cohesives and ensure that everything is removed in toto. You can do your final rotation under BSS. The other tip which he mentioned was pre-positioning the IOL ahead of the mark. Makes sense because if you have to dial, you dial clockwise. Sorry, there's a typo there. Dial clockwise and you don't have to go all the way around in order to get it back into position. So stacking of errors. So if you make one mistake, it can add up all the way down the line and you have an unhappy patient. So you will have to then go back and find out what exactly was the reason and then you're stuck with so many things. If you had multiple errors, they just add up. Problem solving. Stay calm. No toric related problem is unsurmountable, and you can do check on the residual power. We in our clinic do it on the same setting. That is, the patient comes down from the theatre to have his visual acuity checked. Most likely there isn't an issue, so we just leave them at that. And some people choose to check their vision later, and therefore if you need to wait, you need to wait for the back to shrink a bit. A week to 2 weeks would be ideal before you try to do any maneuver at all. Now, why adjust the toric IOL? See, it says for every 1 degree of rotation, there is 3.3% of the IOL cylinder power is lost. And at 30, you completely negate the toricity of the lens you're implanted. And beyond that, God forbid. Why correct the astigmatism? Well, it's a major aberration. It helps the contrast sensitivity preserved. You achieve the least possible blurred vision. So I'm sure it's something worthwhile. And how do you do it? You can redial, you can do a surface ablation, you can do a limbal relaxing incision, or even give glasses if the patient is willing. There are some things which are not in our control at all. These are, for example, corneal scarring and thinning. So if there is any indication that the patient might have an issue, clearly there's a buccal thinning, surgical if the incision architecture is not right, if there's an IOL tilt, wound, if there's a suture, if there's steroid induced. And my take home message, simple, calibrate, do your cornea, make sure it's moist when you're taking your measurements, get your case right, mark properly the methodology you use, and maintain high standards of excellence in your surgery. Thank you for your kind attention.